extra time, we'd be happy to welcome you from the audience to pose questions as we go. Otherwise, perhaps you can meet with the speakers afterward. So thanks very much. Without further ado, I'd like to introduce my good friend and colleague, Tom Tu, who's going to present a case of a difficult radial coronary intervention, no reason to give up. Take it away, Tom.
Great, thank you, Doug. My slides are not up. They're up here, but they're not up on the screen. So I'll talk a little, oh, here we go. So I was asked to present a case about a difficult transradial intervention. No reason to give up, I think, is a nice way of introducing new techniques and perhaps more creative ways of completing a intervention from the transradial or from the arm approach to get the benefits of less invasion and less risk of bleeding. No reason to give up, I think, might be a little bold statement here. I'm going to present a case that's a little challenging, and hopefully we'll get some interaction with the audience to see if they had any suggestions how to better the care of my patient here. I have no disclosures. I'd like to present a case of a 61-year-old man whose only past medical history is notable for distant colon cancer, over 10 years ago considered cured. He had a witnessed cardiac arrest at home, but unfortunately had delay in the initiation of CPR. His initial rhythm when EMTs found him was ventricular fibrillation. He was defibrillated twice with successful restoration of sinus rhythm. As part of his resuscitation, he was intubated. He received epinephrine, amiodarone, and comes into the emergency room with borderline hypotension. Initially, he had some neurologic signs of posturing, but with a little bit of observation, that seemed to be improved. His presenting EKG demonstrates SC elevations in leads V1 and V2 with some reciprocal changes inferiorly consistent with an anteroseptal myocardial infarction. So he was brought emergently to the cath lab for catheterization and hopefully primary PCI. Our strategy in our hospital is a radial first approach for STEMI. So we have techniques and the expectation that these patients will get transradial if possible with a faint radial pulse that is a little challenging sometimes, but we have rapid access to ultrasound-guided access in the radial artery. For those of you who don't use ultrasound-guided access, I strongly recommend it. It's a great technique for safe arterial and venous puncture, and once you get good at it, you can do it quite rapidly, even in settings of cardiovascular compromise. This is, of course, from the literature. We didn't take pictures of our access in this patient. So after we got access in the right radial artery, found a little difficulty advancing a catheter beyond the level of the elbow, and so took an angiogram, and this is what we find.